Thanks very much. So, we need to talk about openEHR and eye care, and I think there's a lot to cover. But there we are. We have a lot to cover, but we have 20 minutes, so we might as well start at the beginning, right? So, it turns out that light contains information that's pretty useful for living beings that don't want to die and that want to pass on their genes. So basically what happened is that for a long, long time, when there were gene mutations that help living beings perceive light, those gene mutations are really doing themselves a favor because it makes them more likely to be passed on to the next generations. So those are two of our ancestors, and all of this started off with just proteins having mutations that make them light sensitive. And if you keep this evolutionary pressure on long enough, we end up with, well, you and me. And this is you when you're about minus 30 weeks old. And that's your brain right there. And all of those mutations have accumulated into like loads of genes that are going to orchestrate a crosstalk between your brain and the rest of the body that's going to give you eyes. And we're just going to summarize that crosstalk real quick. Basically, the brain grows through two protrusions that press against the surface of the body. I'm really sorry about that. And those protrusions are going to say, okay, I'm going to fold in. The brain says, I'm going to fold in on myself and turn part of me light sensitive. Would be really nice if the rest of the body could sort of form a globe around that with muscles on it, so that I can point it to where I want to. So, thank you. And also, this whole organ system leads to fulfill a whole list of specifications that are going to be helpful to help us survive. So basically, the reason you can even see me right now is that for millions of years there has been evolutionary pressure to see or die, and that's have left behind instructions in your genome for your brain to grow out and fuse with the rest of your body to form sort of a high performance 3D camera system. And all of that just in time so that I can project my PowerPoint slides directly onto your brain, basically, well, onto your central nervous system, which is your retina is part of. But of course, with eye care, well, this is an overview of where people are living with reduced sight, and it really sort of tells two stories. On the one hand, it's a bit of a success story that the countries in the global north have managed to keep the vast majority of their population with a good sight, as they have access to modern eye care. But also shows that there are really big challenges in the global south where those resources are not available. And as a function of aging populations and as a function of where populations are growing, the total number of people living with blindness is actually going to projected to increase over the next decades, which would be preventable in large parts because most of the conditions that cause this blindness would be fully treatable if care was accessible. So I just wanted to give you this as a sort of quick backdrop for eye care. But we do need to talk about eye care data, and I want you to understand where I'm coming from, which is Germany. So I'm just going to show this slide and see if you sort of get what the situation is. Right? I mean, that probably makes sense to most of you. Basically, the situation in Germany right now is that it's for people with complex eye problems or other diseases, it's nearly impossible not to have their data spread out all over the place. And those nearly 50 different programs that I'm showing you here, that's from a survey just of ophthalmologists. So that's where eye care data is ending up. And the communication is largely still paper-based. And I look forward to seeing patients that bring a binder of paper records to me because at least I know that I will get an overview. And it used to be that I had to call different other healthcare providers to ask them to fax things to me. But as we now live in the future, increasingly I get AI voice bots answering the call, and they're great, but they're just not connected to the fax machine. So I'm not getting that letter anytime soon. And we're only just now rolling out sort of a national EHR, which is really more sort of a national Dropbox for PDF documents. But the background, to why I'm here and why the German Society of Ophthalmology said, okay, we need an interoperability coordinator, is because we know in the future Germany wants to transition to exchanging more structured healthcare data with using FHIR, and they are sort of setting the necessary sticks and well, carrots and sticks in place to do that. So that brings up the question, or brought up the question to my ophthalmology colleagues, well, how are we going to do that? How are we going to put eye care information into FHIR? And it just so happened that I was already aware that nobody had actually figured that out yet globally. You know, so this was sort of our wish list for things that we would like to build something on when people, you know, when the German governance is going to come to us and ask, you know, how would you like your eye care data exchanged? We know that we don't just want to make things up on the spot. So I was previously, you know, aware that there wasn't really a solution out there yet that is comprehensive, because I was following and I was sort of inspired by the Eyes on Fire project, which was a clinician-led project that sort of went 2020, 2021, and they had a vision of building something that works, data models and FHIR resources that work across different use cases, or at least here's the number of use cases they wanted to cover. So they had some really, really good ambitions, and they did take the initial steps, but unfortunately it just didn't really continue for after the first ballot. So the situation that iCare is, well, still in, is that basically the only sort of domain-specific IG that is out there is neither mature nor widely implemented, and without published and sufficiently mature FHIR IG, fragmentation of FHIR implementations will organically form to support individual research needs, and that's by the MITRE corporation in the think tank in the USA. And so obviously we were having a bit of problem in Germany, because we know at some point we expect to be asked, well, how would you like to exchange visual acuity data? And so this sort of brought about a stage to my work where I sort of thought, okay, there's this IG out there that would have to be improved, and I wanted to see if I can figure out how that would work. Like, how would we build something in FHIR that actually allows us to do that? Because we knew that, you know, a clean slate. Oh, sorry, implementation guide. That's like, FHIR is an data exchange specification. Well, it's basically a toolbox to build data exchange standards, and an IG is what you build with that toolbox. And that basically tells people what exactly goes into which of those letters. You know, where the data that's inside the clinician's head there, basically it defines the data models that are going to be used during the data exchange. And we knew that, you know, there's still a bit of a blank slate out there, and we can build something, but that's a bit like building the first car. When you build the first car, you don't think that you're going to end up stuck in traffic after a few decades. So we just knew that we didn't just want to build anything. We did want to sort of be harmonized with the rest of the world. So that's because I had figured out that, okay, when you build one of these profiles, you can still have, you know, take parts of them and make them more specific, so that you reuse parts of the sort of top level definition. And really, in the end, I realized that what I was trying to build there in FHIR was basically sort of an archetype, because nobody had told me that that's not how it's not usually done. And I do have a poster on that you can either look at, or we'll talk about in that poster session tomorrow. But basically, with clinicians, with a few clinicians being left alone with FHIR, what we started sort of naturally doing was trying to build something like an archetype in FHIR. And that was all before I figured out. So over time, I got in touch with openEHR and I realized that, you know, this is not usually how it's done, and that what I looked at in the CKM, it took me a real while to realize that this visual acuity archetype, for example, isn't already finished, that can still be changed. So I had to stumble across it multiple times to see that, oh, actually that visual acuity archetype is not finished, it's not mature, it's not published, and actually the review has been suspended and little work has been done over the last 10 years. But it took me a while to realize, because at first I encountered it and I thought, okay, nobody's going to change it, but just because I would suggest some changes to it. So I only got in touch with the openEHR community in December last year, and from there I realized that eye care in openEHR at the moment is in a bit of a no chicken, no egg situation, where we have no mature eye care archetypes, so that makes eye care difficult to adopt in our field. That means nobody is aware of it among ophthalmologists, and that means those archetypes aren't really being improved or haven't been in the last 10 years. So to sort of change that, sort of lay the first egg, I initiated a sort of global just volunteer working group of eye care professionals and openEHR experts, with brilliant support from especially Heather, Celia, and Ian, to just build those few first really important eye care archetypes, so that we can sort of exit that vicious cycle and get to a point where they sort of more naturally maintain themselves. So this may not be super interesting to you, but we're definitely we're sort of doing crowdsourced clinical requirement engineering by sort of just gathering clinicians from around the world, showing, okay, what are the special cases of like intraocular pressure measurement? We're discussing that, but we're splitting it from the clinical data modeling discussions. I'm usually the one that's building the drafts based on it. But the really important thing is that we're not just uploading that, but we get the expert feedback from Heather, Sil, and Ian, so that we can get their expertise. Because we don't have one specific use case that we're building for, so it's really important that we align with the existing patterns, because there are no ophthalmologists that are archetype modeling experts right now. And we're making reasonable progress. I think the visual acuity archetype has seen significant changes, but we're not actually getting that to the review first. We are going to try and do that with the intraocular pressure archetype first. And so when I talk to colleagues about openEHR, what I realized is, on one hand, the bad news is that eye care professionals just don't know about openEHR, at least in Germany. I haven't met a single one who knew about openEHR before I talked to them about it. But that means the good news is eye care professionals don't know about openEHR yet, right? Nobody has consciously decided against using openEHR. Okay, so the reason that I'm using it is not because they have decided against it. And my personal impression is that the openEHR approach really resonates with e-health-minded eye care professionals, because we know that what we're doing right now isn't working well. And people don't want to build national solutions. What I also found is that talking to them, doodles and putting lots of stuff on PowerPoint slides actually works well to sort of communicate the ideas of openEHR and the approach, because we don't know the vocabulary, okay? We don't know what a domain knowledge artifact is. That doesn't make any sense to us. And I will just briefly mention that there's quite an important history between openEHR and open eyes, between eye care and openEHR. And to understand that, you need to understand sort of the Open Eyes project, which is an open source EMR for eye care, which was founded at the Moorfields Hospital in London. And it's also managed by a non-profit and led by a community of eye care professionals. And David Ingram was very involved in its development as well, or still is. And when you can read chapter 8 and a half in his book to learn more about it. But basically, he says that had openEHR existed in the form of what is now the EHR-based platform, Open Eyes would have been built on that platform from the start. So it's a bit of a missed connection, really, that Open Eyes is not based on openEHR. Otherwise, the archetypes would be much more advanced than they currently are. But so it's an ongoing conversation if these organizations or the people around them or us will ever manage to change that, and to sort of have Open Eyes and openEHR sort of re-merge together and to tie those two loose ends together. There's definitely interest in doing that, because they are eye care professionals who are really good at gathering the requirements that, like, what do eye care professionals need in an application that matches their workflows, because we're not solving that just by building archetypes. Okay, that experience and that community is extremely valuable if people ever want to make eye care work with openEHR. So this is my close second to last slide. Why is And I just ask myself, why is eye care information difficult to model in the first place? Like, is there anything that's uniquely difficult here, or is it just that I'm complaining about it? And what I found, what's not really unique to eye care is, of course, that we have bilateral sensory organs. So we have to keep the handling of laterality really consistent for safety reasons, and we have to rely on what patients tell us what they see, which can make things rather complicated because we have completely different approach if we're trying to measure vision in children, for example. And that just leads to a lot of sort of variations in our methodology. At the same time, what I think is rather unique to eye care is that if you think about all the ways that eyes should move and all the ways that they shouldn't move, but sometimes do, and then include things like pupil diameter and the sort of accommodations or the sort of autofocus of the eye, and you add that together from both of the eyes, you end up with about 18 degrees of mechanical freedom. So like 18 different ways that the eyes can move overall, and all of that in an organ that people don't like you touching. So that does add some complexity that I think is a bit unique. At the same time, anything that's affecting the light entering the eye can be a variable in some tests. And that means in terms of what we're making the patient look at, we have a huge diversity of tests. And like, just for example, those 3 things I'm showing you there are testing completely different things. And people have been very inventive to come up with new things for patients to look at so that we can test them. And on the other hand, what's the patient looking through? The whole optics are not really covered yet in openEHR, but they're quite an important part, because we can put any number of things in front of patients' eyes, right, left, have them look at different things, and that just adds complexity to the clinical modeling. And of course, light has some intrinsic properties that we need to take care of. There's also the issue of scale difference. The patients enter our room. From the time the patient enters our room, we look at the whole patient, to the point where we look at individual cells in the patient. That's less than 1 minute for us, at least sometimes. So we go all the way down the scale pretty quickly, and only then do we go to the computer to enter all that data. So that will be challenging when we talk about the examination archetypes, I think. And of course, there's also been like a huge pace of innovation in imaging devices, especially in ophthalmology. So when we used to look at those grainy pictures from, it's like a cross-section at the back of the eye, those nearly look at like histological sections right now. And like there's at least research going on that has resolution down to like single cell level without the eye being, open in any way, non-invasively. And when we used to take a quick picture of the back of the eye, it used to sort of look like this, where we can sort of see the bit of the optic nerve, and that's the center of vision right in the middle. And the optics have improved in a way that now this is what we see, where we say, okay, hopefully you're not going to have all of those things at the same time, right? So it's a photo montage, but it just shows you how much can fit in there. And this is how, even 20 years ago, maybe a little bit, maybe 25, the curvature of the cornea was measured so that you know which lens to put in the eye in the cataract operation. And today we're using this equally, using OCT, like fancy technology, expensive devices, and we're measuring loads and loads of parameters in a second. But of course, we should remind ourselves, and this is where we sort of go back to the start, that it's not that these different methodologies are really being replaced, okay? Often they're just sort of shifted from regions with more resources to regions with less resources. So that's a German device right there that's being used in Kenya. And that means the complexity is only ever getting more. The number of archetypes of what they would have to consider is only growing over the time, and that means like the eye care archetype gap that we need to fill is growing and growing and growing with each year. So what's next? I would really like for this to become a Venn diagram, right? So that we can have people with eye care knowledge, people with archetype modeling experience, and they have time to build the archetypes together. We're making a little bit of overlap right now, but I'm predicting if we manage to have the key archetypes published, I think use cases will start cropping up, and we need to make sure that eye care related projects in the openEHR space coordinate early. And I'm going to warn people about it. It's going to be really hard to develop user interfaces for eye care ophthalmologists that don't slow them down. So with things like FIRE and openEHR on a path to convergence, I'm just thinking, please don't leave us behind. Eye care professionals and their patients want to benefit from that too. But I think that we need to make sure that clinical communities understand what the implications are if these open standards are going to converge. Because it changes like what the sort of logical first steps are. Okay, thank you for your attention.